What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my emergency medical services playlist. In previous videos, we talked about the airway, breathing, ventilation, oxygenation, circulation. We talked about examining the scene and examining the patient. We talked about the difference between a medical case and a trauma case. And we talked about the 7 levels of consciousness. Today, we'll dig deeper into the topic of the vital signs, such as blood pressure, pulse, respiratory rate, and temperature. What's the difference between a sign and a symptom? A symptom is something that the patient says. For example, I have a headache or I feel pain. But a sign is something that I, as a provider, is going to detect, such as tenderness, such as a rash on the palate, such as splenomegaly, etc. Click the like button, click the subscribe button, and let's get started. Before watching this video, please watch my video called How to Assess the Patient. And you can find all of these videos in my emergency medical services playlist. In the last video, we talked about the assessment of the scene, the patient, the ABCs, patient priority or transport priority. Should I wait and treat or should I load and go? Should I stay and play or should I grab and go? If it's something minor that you can manage, then wait and treat. But if it's something that is an absolute emergency and the patient has to go to the hospital right now, we're gonna load and go. These patients include the patient who is unresponsive with no gag reflex, the patient who is responsive but cannot follow your verbal commands, the mother in labor or childbirth with complications, severe pain, severe bleeding, dyspnea, and shock. And we talked about the sample acronym in the previous video. Today we shall focus on the vital signs, including the pulse, blood pressure, respiratory rate, and temperature. Notice that I said pulse and I did not say heart rate because they are not synonymous. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. So let's talk about these vital signs in detail, starting with number 1, the pulse. First, we're going to start with the pulse. Remember that in infants, one of the easiest arteries to palpate is the brachial artery. And in adults, the easier ones are the radial and the carotid. Why do I say pulse and not heart rate? Because pulse is an umbrella term that includes many things. It includes the heart rate, it includes the rhythm, the volume, the character of the pulse, equality between the right side of the body and the left side of the body. For example, some patients will have a pulse that is strong in the right arm and weak on the left, or vice versa. Arterial wall. Example, patients with atherosclerosis will have a very stiff artery. The wall is thick and stiff. It feels like a cord under your fingertips. Other pulsations. For example, some patients have pulsations in the suprasternal area, in the suprasternal notch. We call them suprasternal pulsations. Next, the force and the tension. These will help you estimate the patient's blood pressure just by feeling their artery. Skillful doctors are very good at this. A good doctor will just stick his or her fingers on one of your arteries and will say, you know what, your blood pressure is about 125/85. And voila. When you confirm with your sphygmomanometer, it's the exact same number. Very, very few doctors have this skill, but it's an amazing skill to have. Practice makes perfect. And if you doubt the importance of the physical exam, remember that the Winkie-Bach's rhythm in heart block was discovered by this physician before ECG was invented. It's physical exam, baby. Then, if you suspect aortic regurgitation in a patient, you can find the digital pulsations, the special sounds, and the special thrills, and we'll talk about this in detail in my video on aortic regurgitation in my cardiology playlist. Now let me give you a quick overview on each of these topics. And of course, pulse deserves its own video. Rate. The rate could be fast or could be slow. But what's the normal rate? The normal heart rate is between 60 and 90, not 100, but 90 beats per minute. Is this the rate of the ventricle or the rate of the atrium? Ideally, they should be the same. However, in some arrhythmias, the atria is in one land and the ventricle is beating in a completely different land. In that situation, this is going to be referring to the rate of the ventricle. Because when you feel the patient's pulse, for example, in the radial artery, you're feeling the ventricular beats, not the atrial ones. Next, rhythm. The normal rhythm is regular rhythm. So you feel the patient's pulse for, let's say, 1 minute. The rhythm is regular. It does not get fast and then slow and fast, and so it is regular and predictable like a clockwork. What if it's not regular? Could it be irregular? Yes. For example, patients with atrial fibrillation have irregular rhythm, commonly referred to as irregularly irregular. Other patients with irregular rhythm include pulses bigeminy, pulses trigeminy, and even pulses quadrigeminy. These could be caused by digoxin. They could be caused by premature beats. Next, the volume. What's that? Put your fingertips on the patient's artery. How hard the blood is hitting your fingertips is the volume. It's the movement imparted upon your fingertips. What does it reflect? It reflects the pulse pressure. What is the pulse pressure? It is the difference between systolic blood pressure and diastolic blood pressure. So, systolic minus diastolic equals pulse pressure. Patients who have high pulse pressure will have high volume, and patients with low pulse pressure will have low volume. What's the normal pulse pressure? Well, what's the normal systolic blood pressure? Let's say 120. And what's the normal diastolic blood pressure? Let's say 80 millimeters of mercury. So what's the difference between the two? What's the normal pulse pressure? 120 minus 80 equals 40. So the normal pulse pressure is about 40 millimeters of mercury, and this is normal volume. Okay, can you tell me about causes of high volume pulse? Yeah. These are the same causes as of high output cardiac failure or hyperdynamic circulation. We'll talk about them at the end of the video. Let me give you a few of them. Anemia is one, aortic regurgitation is one, pregnancy is one, arterial venous fistula is another one. Next, let's describe the pulse's character. What does that mean? Does that mean respectful versus despicable? Oh, shut up. Then what is character then? Character is the impression of the pulse wave form as you palpate it. I want you to feel your pulse. This is how normal pulse should feel like. So this is the character of normal pulse. Then I want you to palpate the pulse of a patient with pulsus alternans, or pulsus bigemini, or trigemini, or the water hammer pulse, also known as collapsing pulse. There is also pulsus bispherians, etc. All of these are different characters of pulse, different patterns of pulse. Equality, easy. Compare the patient's right arm with the left arm, the right radial artery against the left radial artery. You can palpate both of them together, but never, ever, ever, ever palpate both of the carotid arteries together. Otherwise, you can generate a baroreceptor reflex and the patient might faint. That's dangerous. What are the possible causes of unequal pulse between the right side and the left side? Well, let's say that I have a cervical rib, which is a congenital anomaly, where there is a rib coming out of my neck instead of out of my chest. I could have a cervical rib on the right, but not on the left. So the pulse on the right side will be weaker compared to the pulse on the left. Another famous disease is aortic dissection. Why? Because the aortic arch looks like this. This is the brachiocephalic artery, left common carotid, and left subclavian. Suppose that I have dissection in my aorta here. This is where my aorta got dissected. Then what's going to happen? You will have robust blood flow in the brachiocephalic artery, which goes to the right arm. And you will have weak blood going to the left subclavian, which goes to the left arm. Therefore, you're going to end up with robust pulse on the right side, but weak pulse on the left side. And this happens in aortic dissection. If you want me to make a video just on the topic of pulse, please let me know in the comments. To see more emergency medicine videos in the future, please drop an emergency siren emoji in the comments. Let's just focus on the heart rate component of the pulse today. What are the causes of high heart rate or tachycardia, and what are the causes of low heart rate or slow heart rate, as in bradycardia? Tachy means fast, brady means slow. Causes of tachycardia include if I'm exercising or exertion. If I have fever and tachycardia go hand in hand. Stress, anxiety, or panic attack can lead to tachycardia. Medications, not all of them but some of them, such as atropine and epinephrine. Atropine blocks the parasympathetic. The parasympathetic should slow down the heart, but when you block it, you will speed up the heart. Epinephrine speeds up the heart from the beginning. Anemia can cause tachycardia, heart failure can cause tachycardia, myocardial infarction can cause tachycardia, pulmonary embolism can cause tachycardia, and many cardiac arrhythmias are tachycardic in nature, such as ventricular tachycardia. Next, causes of bradycardia. If I'm sleeping, if I'm resting, if I'm taking a beta blocker or a calcium channel blocker, if someone stimulates my vagus, for example, I could be wearing a turtleneck or a jacket with high collar. What's going to happen to me? I stimulate the vagus and I get bradycardia. This is called baroreceptor reflex. Anytime you stimulate the vagus, usually in the neck, but it could be in other places, you're telling the brain that the blood pressure is high. In response, the brain will try to mitigate this effect by lowering the heart rate. Baroreceptor reflex. To learn more about the baroreceptor reflex, please refer to my physiology playlist. Next, heart block, also known as atrioventricular block. We have many types of heart block and they cause bradycardia. What are the 4 vital signs again? We have the pulse, we have the blood pressure, we have the respiratory rate, and we have temperature. We're done with the pulse, let's talk about blood pressure. To learn more about blood pressure, I have a special video for it. It's called Blood Pressure and Fluid Balance, and you can find it in my biology playlist and in my physiology playlist. What blood pressure are we talking about? We're talking about the arterial blood pressure on the arterial side. Okay, which artery? Are we talking about the aorta or the systemic arteries? Or are we talking about the pulmonary arteries? We're talking about the aorta or the systemic arteries. Where did the aorta come from? It came from the left ventricle. So the left ventricle is going to push blood into the aorta. The harder the ventricle pushes, the higher the blood pressure. The stronger the aorta contracts and shrinks and constricts inwards, the higher the blood pressure. What blood pressure are we talking about? We're talking about the systemic arterial blood pressure. What's the normal arterial blood pressure? It's 120 systolic and 80 diastolic. This is not a division. Just because I said that the blood pressure of the patient is 120 over 80 does not mean that you should do this. Oh, I'm going to cancel the 0 with the 0 and then I'm going to divide by 4. 12 divided by 4 is 3 and 8 divided by 4 is 2. So therefore the blood pressure of my patient is 1.5. What the French toast are you doing? This is not a division. Get your head out of your sphincter. The first number is called the systolic blood pressure, and the second number is called the diastolic blood pressure. Let's define each one. What is the systolic blood pressure? It is the arterial blood pressure in your big systemic arteries, such as your brachial artery, during systole of the ventricle. And what's the definition of diastolic blood pressure? It is the arterial blood pressure in your big systemic arteries, like the same brachial artery, during diastole or relaxation of the ventricle. If you have the normal blood pressure, we call you normotensive. If your blood pressure is high, you are hypertensive. If your blood pressure is low, you are hypotensive. What is blood pressure? Blood pressure equals cardiac output multiplied by the total peripheral resistance. What kind of blood pressure are we talking about? We're talking about arterial blood pressure, not venous. What kind of arteries? Are we talking systemic arteries or pulmonary arteries? We're talking about systemic arteries, such as aorta, axillary artery, brachial artery, etc. And is this formula talking about systolic or diastolic blood pressure? Neither. It's talking about the mean systemic arterial blood pressure. Mean here means average, not nasty. And what is cardiac output? Cardiac output is heart rate times stroke volume. How fast times how strong is your heart beating. If you want to raise the systolic blood pressure, you can raise the cardiac output. And if you want to raise the diastolic blood pressure, you can raise the total peripheral resistance. While it's true that cardiac output can affect the systolic and the diastolic, it usually affects the systolic more. And while it's true that the total peripheral resistance can influence the systolic and the diastolic blood pressure, it usually influences the diastolic more. So why would a patient have high blood pressure? Maybe it's high cardiac output, and maybe it's because of a high total peripheral resistance, which depends on the radius of the artery. And cardiac output is what? Heart rate times stroke volume. So the patient with high blood pressure could have the high blood pressure because of increased heart rate, because of increased stroke volume, or because of increased total peripheral resistance, which can be achieved by decreasing the radius of the artery, as in atherosclerosis, which makes the wall of the artery thicker and the lumen of the artery narrower. Less radius, higher resistance. Higher resistance, higher blood pressure. Higher blood pressure, they call me hypertensive. So what controls stroke volume? The contractility of the heart, which is the force of contraction, and the diastolic blood volume. In other words, it's the volume of your blood. In other words, it's the venous return that returns back to the heart. It's the input to the heart. And if the input is high, the output will be high. And if the cardiac output is high, the mean systemic arterial blood pressure will be high, and this is hypertension. So, causes of hypertension include rapid heart rate for whatever reason, increased cardiac contractility, increased blood volume. For example, the doctor gave me too much normal saline, raising my blood volume and my blood pressure. And or vasoconstriction of arteries, which increases the total peripheral resistance, because when you vasoconstrict, the radius decreases and therefore the total peripheral resistance increases. How can we lower the blood pressure? You either lower the cardiac output by decreasing heart rate or decreasing stroke volume. You can decrease the total peripheral resistance. You can decrease the venous return or the preload, which is going to decrease the cardiac output by reducing the stroke volume. And that's why you can find that the medications that lower the blood pressure work by decreasing heart rate or decreasing stroke volume, such as beta blockers, decrease total peripheral resistance by dilating the arteries, such as vasodilators, as hydralazine and nitrates, decrease the venous return. How can I do this? You can decrease the blood volume. How? By giving a diuretic. Next, what are the causes of isolated systolic hypertension? What does that mean? It means that the systolic blood pressure increases a lot, but the diastolic blood pressure does not increase. It might even decrease. And when this happens, what's going to happen to the difference between the systolic and the diastolic blood pressure? Meaning, what's going to happen to the pulse pressure? And the answer is the pulse pressure will widen. The causes of isolated systolic high blood pressure, or the causes of high output cardiac failure, or the causes of hyperdynamic circulation are similar. And these are A, B, C, and S. The A's: anemia, anaphylactic shock, arteriovenous fistula, acromegaly. And then the B, and if you flip the B, it becomes a P. You have beriberi, which is vitamin B1 deficiency. You have pregnancy, Paget disease, because it has an AV fistula, usually in the bone, because the bones are hypervascular in Paget's disease. Patent ductus arteriosus. You can think of it as a fistula, which is something that speeds up the circulation because you will have to bypass the capillaries. The C, carcinoid syndrome. S, sepsis. Don't forget hyperthyroidism and obesity. All of these patients will have wide pulse pressure. So what causes high blood pressure and what causes low blood pressure? Using this mathematical formula, can you guess what the causes are? Let me know your answer in the comments. Next, the blood pressure cuff, the sphygmomanometer. When should we use it? It has diagnostic value and therapeutic value. Diagnostic value to measure the blood pressure. Therapeutic value. Let's say that the patient is bleeding and you do not have a tourniquet. You can use the sphygmomanometer as a tourniquet by inflating the blood pressure cuff and stopping the bleeding. We're done with pulse and blood pressure. Let's talk about respiratory rate and temperature. Starting with the respiratory rate, not just the rate, but the rate and the depth. This is an alveolus in your lung. Let's bring the oxygen into the lung. We call this ventilation. And then the oxygen will diffuse from the lungs to the vessels, and this is called diffusion. And then the heart should pump blood to the lungs via the pulmonary arteries. This is called perfusion. Ventilation is to bring oxygen to the lungs. Oxygenation is for that oxygen to jump onto the hemoglobin. So ventilation versus oxygenation. Ventilation is to bring oxygen to the lungs. Oxygenation is to dump that oxygen onto the hemoglobin inside the vessel. Ventilation cares about what? It cares about how fast and how strong the lung is breathing. What do you mean by how fast and how strong? How fast is called the respiratory rate, which is one of the vital signs. But the rate is not the only game in town. There is also the strength or the depth of breathing. And that's why you need to have a normal respiratory rate and a normal tidal volume. Normal rate and normal depth equals normal ventilation. That's why my breathing could be fast but shallow, or fast and deep, or slow and deep? What causes my breathing to be fast? Could be exercise, could be exertion, could be stress, anxiety, panic attack, medications like aspirin, could be anemia, heart failure, myocardial infarction, and pulmonary embolism. Yes, pulmonary embolism, the same pulmonary embolism that caused tachycardia, can also cause tachypnea. Next, causes of bradypnea or decreased respiratory rate. These include sleeping, medications, especially opioids as in morphine and barbiturates. Also, diabetic ketoacidosis can have decreased respiratory rate, and of course, coma can lead to decreased respiratory rate. Next, temperature. We're going to talk about temperature very briefly. If you want more detail, I have a video called Fever, Heat Exhaustion, and Heat Stroke, and another video called Hypothermia. You can find both of them in my physiology playlist. What causes fever? Gazillion things can cause fever. A common cause of fever is infections. Infections can lead to fever, they can lead to leukocytosis, they can lead to tachycardia. Bacteria releases pyrogens, which cause genesis of pyro. What's pyro? What is the Pyrex glass? Oh, it's the glass that I can put in the oven because it can withstand heat. So the word pyro means heat. Oh, the pyrogens will tell the hypothalamus to adjust the thermostat. This can reset the thermostat, raising the set point, raising your core body temperature. That's why you are feverish during an infection. Fever could be a good thing or a bad thing. Within limits, fever is a good thing. It helps you destroy this bacteria. But if it becomes very high for a long period of time, it will start to denature your proteins. Your enzymes are proteins, your receptors are proteins, your pumps are proteins, your channels are proteins, your carriers are proteins. So without proteins, you are toast. Medications that can lead to fever include aspirin and atropine. That's why we say we have aspirin fever and atropine fever. Next, let's talk about hypothermia. First, let me tell you that hypothermia is evil. Hypothermia can lead to metabolic acidosis by decreasing tissue perfusion, which is very bad for the kidney. Hypothermia can cause lysis or rupture of your cells. Pachoo! The cell will release whatever was inside the cell, including potassium, uric acid, and phosphate. When all of these things are suddenly being dumped onto the blood, you will have hyperkalemia, hyperuricemia, and hyperphosphatemia. When phosphate is high in the blood, usually calcium decreases. Moreover, it's very hard for your insulin to function if you have hypothermia. Next, hypothermia can lead to pancreatitis. Hypothermia can raise the hematocrit. Hypothermia make it difficult for the coagulation factors to work. When insulin cannot work, you get hyperglycemia. When coagulation factors do not work, you get elevated PT and PTT. Moreover, hypothermia emboldens the spleen to swallow, i.e. sequester more cells. So when your cells are being hidden in the spleen because the spleen is swallowing them, your white blood cells that are circulating will decrease and your platelets that are circulating also decrease. Possible causes of hyperthermia include infections, medications such as aspirin and atropine, heat exhaustion, and heat stroke. Hypothermia could happen because you live in a very cold climate, or if you have shock, which is inadequate tissue perfusion. To learn more about shock, please refer to my emergency medicine playlist. Next, let's answer the question of the previous video. Please choose the highest priority case that needs to go to the emergency room right now. Please pause and try to answer this yourself. The correct answer here is choice E. Now, why is this? Because choice E is a heart attack. This is an old lady with central chest pain, sweating, and blood pressure that is low. This is very concerning because it could be a heart attack. However, mild ankle pain can wait. During labor with contractions that are 10 minutes apart, not urgent yet. Confused but responsive to verbal commands, not an emergency yet. Low-grade fever, not an emergency yet. Speaking of emergencies, I have an emergency medicine high yields course which will teach you about cardiac arrhythmias, myocardial infarction, stroke, acute respiratory distress syndrome, acute limb ischemia, drowning, and lots of toxicology topics. such as aspirin toxicity, digoxin toxicity, atropine toxicity, and more. This course comes with videos, notes, and cases, and you can download this course today at medicosisperfectionalis.com. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, and physics make perfect sense.